Good morning, everyone. This is Dr. Mwala. We're going to be talking about kidney injury in children today. I want us to define acute kidney injury, look at the pathophysiology, the causes, and then develop an approach as well as a management strategy for children with acute kidney injury. So it's taken a long time for us to come up with this whole concept of what acute kidney injury is, and I know at times it can be quite confusing. So I thought we could start from the very beginning by looking back at the fact that humans have always suffered from kidney disease, and as they learned how to write and keep records, we get records from, for example, ancient Egypt that describe the various kinds of diseases that humans suffered from and the treatments and cures that the early doctors suggested for those ailments. This is an example of an ancient Egyptian manuscript, and included in that manuscript is a description of renal diseases such as blood in urine, reduced urine output, and kidney stones. In fact, as we get into ancient Greece, we find physicians such as Galen describing reduction in urine output in his patients. And by the 1600s, physicians such as Morgagni classify reduced urine output as ischemia and use an anatomical classification to come up with causes. So he described reduced urine output as a result of renal problems, ureteric problems, as well as bladder problems. But then it's only after the Renaissance that we begin to get a clearer description of acute renal failure. So by the 1800s, we had a description from William Heberden, where he described patients with reduced urine output in his textbook and associated clinical features in these patients. And by the 18th century, we get the Englishman Richard Bright, who meticulously described the clinical course of patients with various renal conditions and described his findings on autopsy. And because of his major contribution to nephrology, by the beginning of the 20th century, renal disease was actually called Bright's disease and had been classified into acute and chronic Bright's disease. During the First World War, it was noticed that many soldiers who were victims of trauma suffered from a reduction in urine output, and this became known as war nephritis. By the Second World War, we begin to see studies into patients that had suffered from trauma, crash injury, and we get Bywaters and Bill publishing a paper on crash syndrome, in which they further describe this reduction in urine output. And at this time, the histopathological methods and measures of renal function had developed to such a place that they were able to associate these changes in excretion of urine in these patients to acute tubular necrosis. And for quite a while, acute tubular necrosis was used interchangeably with renal failure. By 1950, a physician had coined the term acute renal failure. The problem is that there was no precise biochemical definition of what acute renal failure was, and often people thought of acute renal failure as the most severe forms of renal dysfunction that required renal replacement therapy. The situation was so confused that by 2002, a review that was done found that there were actually over 30 different definitions in the literature of what acute renal failure was. For some people, when they did studies, they said renal failure was when a patient had such severe renal dysfunction that they needed dialysis. For others, a doubling in the serum creatinine was considered to describe renal failure. For others, a change in urine output would be synonymous with renal failure. So because of this, it made it difficult to compare epidemiological studies to describe the burden of this problem in different populations, and then also it made it difficult for people to compare the effectiveness of new treatments that were being developed. So it was difficult to carry out clinical trials using this imprecise definition. So by then, concepts around what constitutes renal failure had changed. There'd been a move from a view of renal failure as occurring at some kind of discrete point to a place where people began to look at renal dysfunction as being a path which occurs as a continuum and associated with various clinical manifestations ranging from minimal but sustained elevation in serum creatinine to patients who were anuric and required dialysis. In addition, work that was done associating changes in serum creatinine to outcomes of patients began to show that even small changes in serum creatinine seemed to have a negative impact on patient outcomes. And so, therefore, people began to realize that earlier recognition of changes in renal dysfunction would allow possible intervention in terms of preventing worsening of the kidney dysfunction, preventing patients from reaching those more severe levels of renal dysfunction. And so therefore, it was decided that a uniform definition was required so that we could better assess the burden of the problem through epidemiological studies, and also use that uniform definition to assess the results of various clinical trials. So between 2004 and 2012, various consensus definitions were devised by different groups. The first group, the Acute Dialysis Quality Initiative, produced what is known as the RIFO criteria in 2004. And then in 2007, the Acute Kidney Injury Network produced their Aiken criteria. They thought it was an improvement on the 2004 RIFO criteria. Then the one that we are using now, the 2012 KDIGO criteria, Kidney Disease Improving Global Outcomes, is sort of a fusion of the 2007 and the 2004 definitions of what constitutes acute kidney injury. So let's start by looking at the RIFO criteria. So this is the RIFO criteria, and essentially they defined acute kidney injury as occurring in a patient whose serum creatinine increases by 50% from a known baseline, or where you have a drop in the glomerular filtration of greater than 25%, or you could use urinary output criteria. So if you had a patient with reduced urine output of less than 0.5 mL per kg per hour for 6 hours, that would constitute acute kidney injury. And then they further classified it into 5 levels: risk, injury, failure, and then they had 2 outcome stages where they talked about loss of kidney function and end-stage kidney disease. So as you can see, this talked about baseline creatinine. Not everybody has a known baseline creatinine, so they proposed that you could use the MDRD formula to calculate what the presumed baseline creatinine would be in a patient. In children, we know that creatinine tends to vary by age. So for pediatric patients, estimated creatinine clearance was used. This is the pediatric RIFO criteria, as you can see, and you use the Schwartz formula to calculate the creatinine clearance. This is the Schwartz formula that can be used. Then, as I said, in 2007, the acute kidney injury network produced this classification system where their contention was the fact that most clinical estimations of creatinine clearance are imprecise. So they introduced the element of using absolute changes in serum creatinine to define what acute kidney injury was, and this change in creatinine had to occur over a 48-hour period. And in addition, you had to make sure that the patient was euvolemic. So if they had been dehydrated, you would have given them a fluid replacement. You had to make sure that there was no obstruction to urine flow. In addition, they looked at the last 2 stages in the RIFLE criteria as being outcome measures rather than staging of the severity of acute kidney injury. So they removed the last 2 stages, and so for the Acute criteria they had 3 stages. And then finally the KDIGO criteria, which I'm about to show. So according to the 2012 KDIGO AKI definition, AKI is said to be present if you get an increase in serum creatinine of more than 26.5 micromoles per liter. That must occur within the first 48 hours. That's from the Acute criteria. Or if you have an increase in serum creatinine of greater than 1.5 times the baseline, which is known or may be presumed to have occurred within the prior 7 days. That's from the original RIFLE criteria. Or indeed, if you have urine output that's less than 0.5 mL per kg per hour for more than 6 hours. The KDIGO 2012 goes on to further classify acute kidney injury into 3 stages, 1 up to 3, and on your right you can see the criteria that is being used to classify acute kidney injury into all of those different classes. And then this table, which you can look at in your own time, just shows a comparison of the various criteria, the RIFLE, the Acute, and the KDIGO criteria based on serum creatinine or GFR, or using the urinary output criteria. So, having looked at what acute kidney injury is, now we can look at the causes of acute kidney injury. Traditionally, we've looked at the causes of acute kidney injury as being either pre-renal, which now people call functional AKI, post-renal, or renal. So let's start by looking at the pre-renal causes. So you have things like shock, all kinds of shock, hypovolemic shock, neuroshock, septic shock, that's associated with reduced perfusion of the kidneys, dehydration, patients with reduced effective blood volumes, patients with nephrotic syndrome, patients that have heart failure, patients with liver failure, or indeed reduction in perfusion of the kidneys associated with changes to the renal vessels, situations like renal artery stenosis. And then post-renal causes would basically be talking in pediatrics about congenital conditions such as bladder outlet obstruction caused by posterior urethral valves, patients who have bilateral vesico-ureteric obstruction, like for example if they have bilateral urethroceles, patients that have neurogenic bladder, so bladder dysfunction, or patients with bilateral ureteric stones or stones at the outlet of the bladder, patients that have tumors in the bladder that obstruct flow. So those would be the post-renal causes. And then finally, renal causes would be those things that damage the renal cells directly. So drugs such as aminoglycosides, things like gentamicin, things like amphotericin B, vancomycin, acyclovir. And then sepsis, apart from the possibility of it causing shock and therefore reducing perfusion to the kidneys, can also directly injure the renal tissue. So that can also be a cause of renal AKI. Other drugs commonly used in our environment, things like tenofovir, that affect the mitochondria in the proximal tubule and therefore lead to renal dysfunction. Then we have glomerulonephritis, things like HUS, interstitial nephritis from various causes, infection of the kidney, things like pyelonephritis, vasculitic disorders, heme nephropathy for things like rhabdomyolysis, things like rapid intravascular hemolysis, which can also occur in situations like severe malaria. All of these are considered to be causes of acute kidney injury. So in terms of the pathophysiology of acute kidney injury, as you can see, acute kidney injury is not a disease. So it's not a single disease. It's a syndrome that is defined by a reduction in the function of the kidneys and therefore a failure in maintaining the homeostasis of the body. So there are various phenotypes. You can get AKI, as I've said, from ischemia, from sepsis, from hepatic dysfunction, from rhabdomyolysis. It can be because patients have received contrast. It can be because they've taken drugs that are nephrotoxic, or indeed it could be because of an autoimmune process. So the exact pathophysiology tends to vary depending on the exact cause of the acute kidney injury. But generally speaking, it's been noted that the pathophysiology, regardless of the cause, involves alteration in the microcirculation. So there's reduction in perfusion in the peritubular circulation, and there are various factors that may contribute to this, things like endothelin and adenosine, for example. The RAS cascade has also been implicated, but essentially this reduction in microcirculation leads to injury of the tubules, because we know that the tubules are involved in transport, and therefore the energy demands of the proximal tubule, the medullary tubules, particularly the thick ascending loop of Henle, are very high, and so any alteration in the microcirculation for those areas will lead to an injury to the tubules. So once the tubules get injured, we get death of the tubular epithelial cells, and those cells begin to drop into the lumen of the tubule, cause obstruction of the tubule, and therefore we get a back leak of the filtered fluid from the lumen into the interstitial space. In addition, depending on the exact mechanism that's causing damage, we get damage to the endothelium, and once the endothelial cells get damaged, we begin to lose the integrity of the barrier function of the endothelium. Again, we get extravasation of intravascular substances into the extravascular space. We begin to get increased expression of intracellular adhesion molecules. This leads to adhesion of platelets, of white cells to the endothelial cells. This triggers the production of cytokines and other pro-inflammatory factors that lead to movement of more inflammatory cells to the site of where the injury is. And so we get a situation where inflammation is activated, and we know that wherever inflammation is activated, there'll be release of oxidative species that may add on to damage to the kidney. And this essentially is the pathophysiology of acute kidney injury. So to sum up, we've said that acute kidney injury is not a disease but a syndrome, and this syndrome is marked by decrease in renal function, and the clinical manifestations may range from just mild to very severe, and that there are various etiologies, and that because there are these various etiologies, the pathophysiological mechanisms may not be exactly the same in all of them. So how do we approach a patient who we suspect has acute kidney injury? So as usual, we start with ABCs. We'll make sure that the patient's airway is clear. You may have a patient coming in unconscious, so you need to make sure there are no secretions. If there are, you suction them. You assess the breathing. Does this patient have pulmonary edema? How are they saturating? Are they using accessory muscles of respiration? If those issues are there, they need to be tackled immediately. Does this patient have effusions that are compromising respiration? If those are there, those have to be dealt with. Does this patient need to be intubated and ventilated? If that's the case, that has to be done immediately. And then, of course, we assess the circulation. So for the circulation, we want to know, is this patient underfilled, euvolemic, or overfilled? So if the patient is overfilled, obviously they'll have edema, they may have an enlarged liver, they will have the apex be displaced laterally, we may have engorged neck veins, and they may even have pulmonary edema. And so our approach would be different for that kind of a patient. Or is it that our patient is underfilled? Are they in shock? What's their capillary refill? What's their blood pressure? What's their mean arterial pressure? Are they dehydrated? What's the skin turgor? So we need to assess all of those things and respond appropriately. And then we'll use a systematic approach in both our history and physical examination. That means we want to find out how long the problem has been there. We want to find out the things that are associated with the primary presenting complaints. Are they passing urine? Was there blood in urine? Any pain when passing urine? What's the urine stream like? Do they have any masses in the abdomen? Is there a family history of kidney disease? Do we want to find out where they live? Is it possible they could have been exposed to some toxins? We would like to find out whether there's been trauma to the abdomen that could lead to damage to the kidneys. We want to find out associated features such as signs of arthritis, features of arthritis, skin rashes that could give us a clue as to the possible cause. We would want to find out, how is the back of the patient? Is this a patient with spina bifida or cauda? What's the tone in the lower in the lower limbs? Is there increased tone? Okay, and then we examine the patient as well, trying to get a clue about first of all the status of the patient and the possible cause of this acute renal failure. At the end of our assessment, we will be able to say whether the patient is euvolemic, whether they are hypovolemic, or whether they are fluid overloaded. And hopefully at the end of our initial assessment, we should be able to say what we think the cause of the renal failure is. Then, in terms of exact management of the patient, the investigations are guided by what you may think the cause of the renal failure is. But for all patients, obviously with renal failure, we want to do a full blood count. Full blood count would be useful. For example, if you look at the HB, you want to see, is there anemia? It could give you a clue. For example, if the platelets are low, HB is low, things that can cause that are, for example, HUS, thrombotic thrombocytopenic purpura, and in our environment, don't forget malaria. You want to see if there are signs of inflammation in this patient. What's the ESR? Is this a patient who could have some kind of autoimmune condition? Am I dealing with a patient who has sepsis? What's the C-reactive protein? What's the procalcitonin? And then we look at establishing that the patient actually does have renal failure. So we'll do urea, we'll do creatinine, we'll do electrolytes. If you can, you establish what the bicarbonate is, and then the magnesium and the phosphate. And then we also want to do some imaging to make sure that the patient does not have post-renal failure. So as soon as we can, we ask for a kidney, ureter, bladder ultrasound to check for the possibility of any stones, any masses, any hydronephrosis. And then we'll obviously send out the urine for microscopy. We're interested in looking for any casts in the urine, which would be suggestive of, for example, glomerulonephritis. And then, depending on the presenting symptoms, you may also want to ask for a renal biopsy as soon as your patient is stable. If, for example, a patient presents with skin rash, arthralgia, renal failure, or if you can't quite figure out what's causing the renal failure or AKI, it would be a good idea to do a renal biopsy. Or if you think you're dealing with a patient who has rapidly progressive glomerulonephritis, you would then want to do a renal biopsy. So in terms of managing acute kidney injury, we can divide the management into dialytic management, meaning we are doing dialysis, or non-dialytic management or conservative management of the acute kidney failure. So the first thing that we need to do is ask ourselves what is the estimated glomerular filtration rate for this patient. And in children, remember, we're going to use the Schwartz formula, which is 40 multiplied by the height of the patient in centimeters divided by the serum creatinine in micromoles per liter. Once we know what the estimated GFR is, it will help us to decide on, for example, drug dosing. We'll be able to get our BNF and decide whether we should hold certain drugs, whether we should adjust the doses of certain drugs. The second thing that we are going to do is to ask ourselves if we can prevent further injury. So preventing further injury, for example, if our patient's blood pressure is suboptimal, we're going to ask ourselves if we need to give a fluid bolus. Do we need to give vasopressors such as adrenaline, such as dopamine? No adrenaline, to support the BP so that we hit the target mean arterial pressure. Then we're going to ask ourselves, is there anything that this patient is taking that's causing ongoing damage to the kidney? So are they on gentamicin, for example? We're going to take off the gentamicin. Are they on acyclovir? And do they need to be on acyclovir? Could it be the tenofovir? We'll ask ourselves all these questions and try and remove anything that could be worsening the damage to the already damaged kidney. And as I said earlier, we'll ask ourselves, is it possible this patient could have obstruction to the flow of urine? So we'll feel for the bladder. We'll do an ultrasound as soon as possible to rule out obstructive uropathy. If that is there, we'll push in a catheter, or if the obstruction is higher up, we'll contact the urologist to see if they can bypass the obstruction. And then optimize the blood pressure, as I said. If it's too high, we'll control it. If it's too low, we push it up by giving fluids or vasopressors. And then we need to ask, obviously this patient is not passing urine. So therefore, if we continue to allow them to take the normal maintenance fluid requirements, they will end up fluid overloaded. They'll end up with pulmonary edema. So therefore, we need to monitor this patient in terms of their weight, in terms of actually doing frequent physical examinations, examining for edema, examining for the apex beat, engorgement of the neck veins, checking for hepatomegaly. And then once the patient comes in, we're going to, our aim is to make them euvolemic. So if they're underfilled, as part of our emergency management, we'll have rehydrated them. Once they become euvolemic, then we begin to restrict their fluid intake. we restrict it to insensible losses plus urine output. So on the first day that we see the patient, if the patient is anuric, we'll restrict them to just insensible losses, which are 400 mils per meter squared, and then we monitor them. If the next day when we see the patient has passed 200 mils of urine, it means that their fluid intake for that day will be insensible losses, the 400 mils per meter squared, plus whatever they passed the previous day as urine, in this case 200 mils, and give that. If there are any other losses, like if the patient has an active NG tube or if they have a colostomy that's very active, we'll add on all of those losses and only replace the insensible losses and what has been documented as losses for the patient. If the patient can take the fluid orally, the fluid will be given orally. If the patient is, for example, new by mouth because they have paralytic ileus or they are post-surgical patients, then obviously that fluid will go in IV. Depending on the potassium status of the patient, we'll try and stay away from potassium containing fluids, unless of course they are deficient of potassium, in which case we'll replace it. And then in terms of electrolyte management, we keep a close eye on the potassium. Often when patients come in with acute kidney injury, they have high potassiums, but it's not in all of them. There are some who may actually have the low potassium, but by and large, many will have the high potassium. So we look out for that, and to manage potassium conservatively, we'll reduce potassium intake by reducing intake of foods that contain potassium, things like citrus fruits, things like processed foods, crisps, jiggies. We'll advise them to stay away from bananas. If they're passing a little bit of urine, we may prescribe furosemide, which is a potassium-losing diuretic, as a way of getting rid of potassium. And then we can also use potassium binders, things like Kayexilate, which can be given either orally or rectally. And then we need to keep an eye on the phosphate. Often patients that have acute renal failure will have a high phosphate. So if this patient is taking feeds orally, we are going to restrict their intake of phosphate containing foods. If the phosphate is high and the patient is new per mouth, obviously we can't use phosphate binders like calcium carbonate, so that would be an indication for dialysis. We'll keep an eye on the calcium, which generally tends to be low in patients with acute kidney injury, and replace orally by giving calcium carbonate between meals. And then we have bicarbonate, which again, because of the acidosis associated with acute kidney injury, may be low. We can replace that orally as well. If we are not able to manage the bicarbonate, the acidosis medically, that would be an indication for dialysis. In addition, we need to watch out for patients developing hyponatremia, and if this can't be managed medically, we would then go on to do dialysis. Often you come across patients with AKI and they have a high blood pressure. Many of them will be having seizures. These seizures may be, as I say, because of the hypertension, maybe because of low calcium, maybe because of low sodium. There are many possible causes of seizures. It could be because of the primary disease, for example, if they have thrombotic thrombocytopenic purpura, or if they have some other kind of autoimmune condition that also affects the brain. So the key thing is not to just give anti-epileptic drugs. The idea is to try and figure out what is causing the seizures. Is it hypoglycemia? Is it hypocalcemia? So you do bloods, and then obviously drug of choice would be a benzodiazepine such as midazolam or diazepam. And then just to remember that whenever you give drugs to abort seizures, there's the risk of causing respiratory arrest in these patients. So just make sure that you are ready to support the breathing of the patient once those are given. Don't prescribe phenobarbital, prescribe diazepam, give it to a patient and walk away from them. You need to monitor them very closely to make sure that they do not get major respiratory depression. And then obviously we need to keep an eye on the nutrition of the patient and make sure that they're getting enough calories. If, for example, we're dealing with an infant where the bulk of their nutritional input is in terms of fluid and we have to severely fluid restrict them, in order for us to meet these nutritional requirements, we may have them to start dialysis if we foresee that this patient will have acute kidney injury for a long time. So in order for us to maintain their nutritional requirements, this then becomes an indication for dialysis. So obviously, if any of those conditions for managing patients conservatively fail, we're going to need to institute dialysis. So if your patient who is anuric has a potassium greater than 6.5, that's an indication for dialysis. Obviously, in the interim, while waiting for dialysis to be established, we follow the hyperkalemia protocol, which includes cardioprotection with calcium gluconate, use of salbutamol, which can be given nebulized, 2.5 milligrams nebulized continuously to children less than 5 years, and 5 milligrams nebulized continuously to children older than 5 years. If the situation is dire, you may need to give glucose together with insulin while you wait for dialysis to be established. You can also give bicarbonate to alkalinize the patient so that we induce movement of potassium into the cells. Lasix can also be given if the patient is passing a little bit of urine to try and induce loss of potassium through the urine. If our patient who we've been managing conservatively develops severe fluid overload, so pulmonary edema, or if we are unable to manage hypertension using medical means, that would be an indication for dialysis. If we have a neonate with a urea greater than 30, or in an older child a urea greater than 40, that's a soft indication for dialysis. Patients in whom electrolyte imbalances have not been managed, so for example patients with hypo or hypernatremia, or patients with acidosis, that becomes an indication for dialysis. Or in patients that have multi-organ dysfunction, including renal failure, we would want to dialyze them. Then patients requiring blood products, because we know that when we give blood products, that constitutes giving volume to these fluid-restricted patients. So therefore, they are at increased risk of developing pulmonary edema, and so we would want to dialyze them. In addition, if they're receiving packed cells would have a higher content of potassium, so that there's a risk of inducing hyperkalemia in a patient with anuric renal failure, and so therefore that becomes an indication for dialysis. And then finally, in patients requiring nutrition, in whom fluid restriction entails that we are severely restricting their caloric intake, we would want to do dialysis. So your patient who has been kept nil by mouth and is receiving total parenteral nutrition, to make room for that total parenteral nutrition, you would institute dialysis. Or in infants where we foresee that the renal failure will be present for a prolonged period of time, because we know that infants take in most of their calories in the form of a liquid, milk, we would then institute dialysis in order to make room for their nutritional intake. So, as we know, there are two types or two forms of dialysis: peritoneal dialysis, hemodialysis. Peritoneal dialysis can be done almost anywhere. It's a low technique sort of dialysis. You don't need electricity. It has the advantage that in children you do not have to struggle to get access to blood vessels. The catheter can be placed into the abdomen, so it's a technique that can be done even in the tiniest of children. Preemies as small as 500 grams to big children weighing over 70 kilograms. And then the other advantage is it's a continuous renal replacement therapy. You can use it as such in acute kidney injury, and also can be used in patients with hemodynamic instability. Then we have hemodialysis, which obviously has better clearance than peritoneal dialysis, which can be used. And there are actually slower forms of hemodialysis where you would do continuous veno-veno diafiltration as a form of treatment in the pediatric ICU. In terms of outcome for acute kidney injury, you can either get complete recovery, you get patients who end up with chronic kidney disease, they have residual dysfunction, or you get the unfortunate few, depending on the cause of the AKI, who end up with end-stage kidney disease.